Hey everyone, welcome to the Trial Site News podcast. I'm Dr. Erin, your host, and today we have Dr. Klausner with us from California, and we're going to talk about a hot topic in the news, which is natural immunity versus vaccine-induced immunity. Dr. Klausner, thank you so much for joining us today.
Very happy to be here with you all.
And if you don't mind, could you give a brief description about who you are and what you do?
Sure. So I am a infectious disease specialist, also a medical epidemiologist. Currently, I'm a professor of medicine and population and public health sciences at the Keck School of Medicine, University of Southern California. Immediately prior to this, I was a professor of infectious diseases and public health at University of California, Los Angeles for about 10 years. And then for the prior 15 years, I was a health official with the CDC. I led the CDC PEPFAR program in South Africa for AIDS and tuberculosis. And then for about 12 years, was a deputy health officer in the city and county of San Francisco, where I led programs around STD, STI prevention. So, I feel like I have a fair amount of direct public health experience and academic experience. And right now, I mostly do research in the prevention and control of infectious diseases.
Thank you so much for that. So you authored a review, one of three authors, I think, called A Systemic Review of the Protective Effect of Prior COVID Infection on Repeat Infections. So can you talk a little bit about that review and what your findings were?
Sure. Well, this really started almost about 6 months ago. As a physician, I was getting a lot of calls and requests from patients and from colleagues about people who have recovered from infection, and they were confused about whether they needed to be vaccinated or not. So right now, the CDC recommendations are if you've recovered from infection, you should wait at least 90 days until you're vaccinated, but they recommend everyone gets vaccinated regardless of prior infection or not. And additionally, a lot of different organizations were developing their workplace vaccination requirements. And as a former public health official, I was very supportive of additional requirements that would increase vaccination, particularly among healthcare workers, nursing home staff, essential workers, frontline workers. That really, I thought public health did a disservice for the beginning of the epidemic by not routinely recommending testing. So now we had a new tool, vaccination. The vaccination is very safe, appeared to be very highly effective, preventing infection, hospitalizations, and death. And, I really wanted to see that scaled up. But again, I was getting questions from organizations, people who have recovered from infection. Do we have to mandate vaccinations in those individuals? And as I looked around the world, I was seeing, a variety of different policies in place in the European Union. They, have their certificate, which allows you to travel between countries, allows you to go into different, restaurants, bars, clubs, whatever. And basically, in those settings, you're allowed to do things if you've been vaccinated, if you have a negative COVID test in the past 72 hours, or if you've recovered from infection in the past 6 months. So in the European Union, they recognize recovery as evidence of immunity. And then they have the same, kind of policies in Israel as well. So, I was a little bit confused why, we didn't have those policies in the US, and I wanted to understand what the data really were. So one of my jobs, I'm the medical director for a very large COVID-19 testing company. And as part of that, we've done over 7 million tests since the beginning of the epidemic. So I was able to look at the testing histories in our employees who work in the laboratory and get tested every day. And I was able to see, okay, well, people who tested positive last year, how many got tested, positive again this year? And, I was surprised the answer was 0. So no one who had previous infection tested positive again. And these are laboratory workers in Texas and Florida, in Washington, D.C., and Los Angeles. So, they are in, major urban areas where there's been lots of cases. So at first, I wanted to make sure that wasn't some kind of fluke. So my research team and I started to look around for other studies, and we found about 10 other studies from a bunch of other countries, Denmark and Italy and Spain and South America, which were all reporting on the frequency of reinfection among those who had previous infection. And I was struck how low that was. It was about 1%. And then when you compared that frequency of repeat infection of about 1% in people who recovered versus people who were unvaccinated, the difference in the relative protection was about 90%. So I said, okay, so if you've recovered from infection, you have a 90% level of protection versus someone who's unvaccinated of getting a repeat infection. And that 90%, is what we've been, putting out there for the benefits of getting vaccinated, right? We say, okay, well, the vaccines are roughly about 90% good against, serious illness, hospitalization or death. Depending on the data set, it may be 95 to 98%. Now with Delta, depending again on the data set, it may be, down to 40 or 50%. There's issues of waning immunity, but, all that aside, the protection from prior infection looked, very good epidemiologically. So as an epidemiologist, that's kind of what I look at when I study are these large populations and large data sets. So then, when we think about, I put on my, kind of other medical research hat, I think, okay, well, what does the immunology tell us? What do immunologists say about, the durability of protection? We know that protection is more than just the antibodies. It's actually, about the cellular immune system as well. So we have, plasma cells, which will then generate new antibodies. We have T cells and T cell subsets. We have memory B cells. There's natural killer cells. There's a lot of different cells involved with immunity. And the studies where they've looked at people over time, show that they still have evidence of immunity. And then we looked a bit further, and there was a study in 2018 that looked at people who survived the 1918 pandemic, and they still had evidence of immunity, nearly 100 years later. And then we also looked at reports from survivors of SARS-CoV-1 20 plus years later, and they still had evidence of immunity. So, it's made me think, okay, well, when I was in medical school in the 1980s, they taught us, if you recovered from infection, except for certain kinds of infections, but in most infections in which you recovered, you were immune from repeat infection, unless somehow that infection changed. So we know with influenza, the virus changes from year to year. So it's not a surprise that you're not, protected after one infection for the rest of your life. But with other infections like, measles, mumps, rubella, other types of viral infections, you recover and then you're immune. So I wanted to understand that further. So that was really kind of the, impetus behind doing this systematic review to look at the current studies.
Okay, so you talked about how natural immunity recovering from infection compares to the unvaccinated. Can you comment on how it compares to the vaccinated and up against the Delta variant?
Right. So and also to be clear, so I generally don't call it natural immunity. So I don't want to confuse people to think that they may just be born with some type of immunity that magically protects them from COVID-19. I mean, we haven't seen that. I mean, we see that rarely, with something like HIV. About 1% of the Caucasian population are naturally immune to HIV. But in general, we don't see that populations are just naturally immune. So I've been trying to, call it, immunity after infection or immunity after recovery from infection. And, so the, question is, okay, well, what's the benefit of vaccination, after you've recovered from infection? Is there additional immunity that is more protective? So, without a doubt, we've seen, several studies across the world that if people get vaccinated after they've recovered, they will have an antibody response. And that's expected. If I expose someone to more antigen, to more virus, their body will react by producing antibodies. The antibody titer will go up, But importantly, we have to remember that antibody titer will go down. And that's natural, that's normal. If we maintained high antibody titers to everything we were always exposed to, our blood would essentially clot and thicken from these antibody proteins. So our body has to downregulate, it has to slow down the production of antibodies. And that's why the immune system goes into the memory mode. So, it has cells that live in the bone marrow and the lymph nodes. So if it sees that antigen or virus again, then in a couple of days, boom, it'll start producing more antibodies and more immune cells. So it's not surprising, yes, after someone who's recovered from infection, they get vaccinated, boom, they have an increase in antibodies and antibody titers. And that's often what you read in the media, the general media, that, well, that confers more immunity, that confers more protection. But the truth is we don't really know. So we have to look at clinical studies, and that are people who have been immunized, vaccinated after infection, do they have a lower risk of repeat infection? And the answer to that is, honestly, we don't know. There's one study that the CDC put out where they looked at people in Kentucky. So Kentucky, which is, a bit of a unusual population by at least, California and New York standards in terms of how people, might approach their ideas about COVID and vaccination, et cetera. But they looked at people in Kentucky, and they looked at people who were vaccinated in Kentucky after they recovered, and people who were unvaccinated in Kentucky after they recovered. And they found that the people in Kentucky who were vaccinated had actually a lower risk of repeat infection. And a lot of epidemiologists are concerned about that study in particular because it could be what's called confounded. So the people who got vaccinated in Kentucky are probably very different than the people who did not get vaccinated in Kentucky after infection. And the people who got vaccinated are probably more of the type of people that would adopt other protective behaviors like mask wearing, like social distancing, like avoiding, crowded indoor settings. And we would expect those people to have a lower risk of infection anyway. So we don't really know, was it their personal behavior and the protective behaviors that protected them, and getting a vaccine was just another sign of that protective behavior, or was it the actual vaccine that protected them? So we're doing additional studies now to try to look at that. But, the best way, which I'm not sure will ever occur, is you really want to do a randomized controlled trial, placebo-controlled trial, take people who've recovered, give half people, another real injection, give half the people a placebo injection, and then see what their risk of repeat infection is. And that would be the best way to really determine whether, additional shot or shots after recovery, because now most requirements for vaccine passports for entry, require 2 shots. So medically, we think probably 1 shot is more than enough if it's required at all. But all the laws that are being written in many different countries, including the city of Los Angeles, where I live, require 2 shots.
I think in New York City, it's 1 shot, the vaccine passport, to get into different places. But I saw in California, they said fully vaccinated, which is the 2 shots, or I guess 2 weeks after that, technically, right? So I've seen this a lot on social media, and I'm glad you brought up the point about natural immunity, because I agree with you. I think that can be very confusing to a lot of people. So maybe naturally acquired immunity, something like that, is better. A lot of people they say like talking about natural immunity is taboo. It feeds into an anti-vax narrative. And other people have said, oh, it's unpredictable. And, and I think the media and a lot of people on social media are like kind of downplaying it or viewing it as something dangerous. And what are your thoughts on that? How do you approach that?
Well, yeah, I think, let's say, mainstream public health officials and leadership, want to keep things simple, right? And they're afraid if you make it a little too nuanced, that, you're going to undermine the main message, which is everyone must get vaccinated, right? That's a nice, simple message. Everyone must get vaccinated unless you have a severe allergy and you're going to die from vaccination. It's easy to count potentially the number of people who've been vaccinated, although now there's all this issues of overcounting for non-residents and people in Florida who didn't live in Florida. And, over 100% of people in some groups have been vaccinated, which is not possible. But nevertheless, it just makes it easier and simplifies the message. But, I think it, undermines people's intelligence. And, it somewhat disrespects people's ability to understand nuance, and also denies, the reality that people who have recovered and suffered through, sometimes very severe, life-threatening, cases. I mean, we should respect the immunity that they've acquired. I mean, without a doubt, it's much, much, much safer to become immune through vaccination than acquiring infection. And no one in their right mind is recommending people go out and get infected in lieu of, getting vaccinated. So no one, is promoting, infection parties and anything like that we used to hear about my parents' generation doing with chickenpox. But, so the vaccine is safe. The vaccine definitely works. But, the issue is that people who have recovered, should they be denied access to travel, to, work, to, going into events? I mean, I tell my patients, yes, get vaccinated. Even if you've recovered, the vaccine's safe. It's not going to be harmful. But if, someone chooses not to get that, it's hard pressed for me to, as a scientist and as epidemiologist has looked at this, it's hard pressed for me to say, well, you're really doing yourself, a lot of damage and incurring a lot of risk by not getting vaccinated. Sure, comply with the rules is always best. I live on a canyon road. The speed limit is 25. I drive the speed limit. If I'm not happy with the rules, I try to use evidence and persuasion to change the rules. But the rules are people have to get vaccinated. They should get vaccinated. But if there's a scientific medical, reason that some people could be exempted, I think we have to, look at that.
So I wanted to talk a little bit about the mandates, because they're everywhere and lots of people are unhappy about it. We're really divided over this issue as a country. So people probably shouldn't lose their job, their livelihoods, if they've recovered, based on everything you just said. What would be can you propose an alternative? Is there some other way that these, what sort of proof of immunity could somebody use to get into a restaurant or a gym in California?
Right. So I think, and the FDA has been very, careful on this. So, the antibody tests, there's no level of antibody, quantity of antibody, measure of antibody that would prove immunity. But the test will prove that you've been previously infected. So, a positive PCR test that you've had in the past will prove you've been previously infected. A positive antigen test that's done at a, clinic or, medical setting could prove you're infected. I'll be a little bit, skeptical about some home antigen tests, which works, but in terms of proof of someone that's had, prior infection. So you have a positive, previous PCR test, positive previous antigen test. You could have a positive antibody test in the past or currently, right? I mean, we know some percentage of people do lose their antibody over time. And again, that's expected because you don't want the body to keep producing high antibodies forever. So, if you have a past history of a positive antibody test, or there's a fourth test called the T cell test, which you can also get, which will show that your T cells have seen SARS-CoV-2 infection in the past. So there are actually multiple ways that you can have microbiological or medical evidence that you've been previously infected. And then if you're deemed previously infected, through any of those tests, that would suffice. So that's how it works in the European Union or in Israel. You just need to show presence of, evidence of previous infection. And, I've spoken to a lot of health officials in cities and states over the past 6 months, and they fear that's a little too complicated, that, who's going to review that? But, we have people supposedly reviewing, their vaccination verification. We also have, in California and in New York, right, you have electronic verification systems. In California, your vaccine record gets extracted from the state record database, so that, the doctor or, whatever site you got vaccinated in, if it was Dodger Stadium or, at a CVS or, Walgreens or pharmacy, when they vaccinate you, they put in the computer, goes into the state registry, and then you get a card, an electronic card, like an e-card, from this company called Healthvana. They're the kind of intermediary, Healthvana, and you have your Healthvana card, which shows proof of vaccination. So you could have the same kind of thing with proof of prior infection. So we actually have that with HIV infection, with hepatitis C, with some other infections. It's not that difficult to have someone be able to carry proof of prior infection. And that's subtly different than having, proof of immunity, right? Because the FDA will not come out and say any specific test now proves you're immune. So what I'm saying is, fine, don't prove you're immune, just prove you're previously infected, and people who are previously infected, based on the data, are protected from repeat infection. Right now in Israel and the European Union, that's good for 6 months. It's probably, could easily be extended to 12 months. At some point, they'll keep being extended to 18 months or 24 months as we get more experience. But just carrying proof of prior infection, would be sufficient and equal to a negative test in the past 72 hours or, proof of vaccination. I'm actually surprised in New York it's just 1 shot, and California is 2 shots, but that's good. I mean, at least it shows that people have been vaccinated. But to me, that would be an opportunity. And then in the workplace setting, people have a little bit more time, and human resources departments could look into this a little bit more deeply in terms of what are people's proof of prior infection, right? So human resource departments are looking at, proof of religious exemption, right? And a lot of that is a self-attestation, right? You fill out a form that says, I hereby declare it's against my personal or religious beliefs to get vaccinated. And because HR departments are so risk averse, they, accept that. So like LA Police Department, LA Fire Department suddenly became very, very religious. All of a sudden, we have thousands of frontline police and firefighters who are very religious and, are given opportunity to decline vaccination. But I mean, a more legitimate opportunity for them to decline would be to show previous infection. And then, people who are not previously infected or unvaccinated, that becomes a smaller group. And then it becomes, to me, it becomes more acceptable to people to say, okay, well, now we really know you're at high risk, right? You haven't been previously infected, you're not vaccinated, and with the Delta variant, you're going to get infected. The good news is that previous infection does protect against the Delta variant as well. So the study by Dr. Gazette and colleagues that was published out of Israel was generated a lot of media attention. And so it was a very large study. And that study showed that even in the presence of circulating Delta virus, people who had recovered from infection had better immunity than people who were vaccinated.
Can I ask you about that study? Just because I was reading online, I came across this slide deck and they were criticizing that study. That study was huge. There was so many data points in that study. But some people were explaining it away, saying selection bias and survivorship bias.
Right. So, I mean, there's always a concern with observational studies, when they're not a randomized controlled trial, that, people who are, included in subtype analysis, may have some inherent differences or inherent quality. So if you read the New York Times, I think today, they talked about, well, this inherent bias, this survivor bias, that people who did not survive are not included as people who recovered from infection. That's true, but I don't think that really makes a difference, because people who have recovered are the people that we're concerned about in terms of are they protected from repeat infection. And then there's also the characteristics of people. I mean, even in Israel, the people who rush to get a third shot on their own are different than people who did not get a third shot. And, again, the people who rush to get a third shot tend to be people who are more concerned, tend to be people who, may have jobs that allow them to have the time off, may not be the essential kind of workers or, factory workers or, people working in crowded indoor settings. So their risk is lower. So that would, kind of mitigate that difference. But, this Israel study now is not by far the only study. And in medical research, when we see studies that are consistent from multiple populations that are done by lots of scientists, right? Very different scientists who do studies a little bit differently. They have different biases, they make different errors, et cetera, et cetera. But when they all point in the same direction, and we see that consistency of effect, that's much more compelling to us that the data are real. And then in addition to those real data from the epidemiology studies, you have the biological studies showing that, people have T cells and B cells and CD4 cells and CD8 cells, in their bone marrow and their blood for, I just saw one that was up to 15 months, for up to 15 months. And then you have animal studies, right? So no one's even been recently talking about the animal studies where you cannot reinfect a rhesus macaque monkey after they've recovered, right? So, we did a lot of our vaccine trials in early monkey, models, et cetera. And very early on, it was showed that rhesus macaques could not get reinfected. Why is that? Because they develop, adequate immunity after exposure. What I'm waiting to see, which honestly I don't know if they're doing, is, do they have monkey models that now were infected a year ago that recovered and now they're challenging, right? So how long and durable is that protection in the monkey model?
Real quick, does the severity of the infection matter for the durability?
Right, so that's a good question. So from the epidemiologic studies, it appears not. That severity does not, offers and recovery superior protection epidemiologically in terms of clinical outcomes. From the immune studies, looking at antibody titers and the duration of antibodies, it appears yes. So the more severe infection you have, after you recover, the more antibodies you have, and then the longer those higher antibodies will persist. So that's potentially one argument that, the amount of antibody is less important than the, cellular immunity you develop later on. I mean, and, honestly, it's really hard to tell because the frequency of reinfection is so low. So like Alabama came out with a report this morning that 8,080, repeat infections. So everyone must get vaccinated. 8,000 repeat infections in Alabama. So I looked up, well, how many infections has Alabama had? So they have 800,000 reported infections. So that's basically 8,000 out of 800,000. That's 1 out of 100 or 1%. So yeah, when you get down to 1% frequency of repeat infection, that's so low, it's hard to parse that out. Of those reinfections, how many were in severe, how many were in moderate, how many were in asymptomatic. And, it really looks like it's a little bit all over the place and there's no specific trend. I mean, it may have more to do with the exposures people have, right? So we think that people who have a more heavy exposure are more likely to get reinfected than if you have a lighter exposure. So that's kind of a variable that we don't really know how to account for.
Thank you. And my last question for you, and thanks so much for your time. It was really interesting, and I look forward to hearing what our viewers think about this. So if you were in charge right now of the public health response, how would you tweak it?
Well, no, I certainly tweak it with, more, regular, clear scientific updates, coming out of the CDC or NIH. So when I ran the health department or part of the health department in San Francisco, we had, monthly updates, and we always had, ongoing updates in research or ongoing updates in data. So I would, have like a weekly scientific update, and I'd have the policies updated to match, what the new information in science is. So now that we have new information about the durable and strong protective effect of immunity after recovery from infection, I'd want the local policies to be updated to, now include, well, it's not a vaccination passport, it's an immunity passport. And if you have immunity either through vaccination or immunity from recovery from infection, that should give you equal, freedom to access, to travel, to go to work, etc. I'd also want to, more granular data, at the counties in terms of, okay, what type of, county transmission is there going on now? How does that inform us about, what should be going on with indoor masking? I was never, really a big fan of indoor masking for individuals who are vaccinated. That was not going to really, have a big impact. And generally, personally, I like to double down on things that I know are important and make a difference. So I was very, bullish on doubling down on vaccination. I thought we should have had vaccination mandates from the get-go, from January 1st last year, as soon as, more vaccine became available, that, the people at highest risk, the elderly, people in working settings where there was high exposure, that there should be vaccine mandates there. But of course, with exemptions, for people who were allergic or people who had recovered from infection.
Thanks so much, Dr. Klausner. I really appreciate you coming on and sharing your perspective.
All right. Well, I really
yeah.
enjoyed talking to you today.
Thanks so much. Enjoy the rest of your night or day out there in California.
All right. Take care. I see the dog.
Yes, he decided to photobomb right at the very end.
All right. Very cool. All right. Bye-bye.
Bye-bye.